This is a case that I think we can use to demonstrate the pearls that will help us more consistently achieve success with the Crystalens accommodating lens. And this is a only slightly edited procedure, and the first thing that I really would tell you is when you're doing this surgery, when we got into premium lenses, we slowed down. We used to get up to as many as 8, 10, sometimes 12 cases an hour. We're probably doing half of that on a good day right now, between marking for toric lenses and all the things that we do that really help us with our crystalline surgery. So the performing the capsulorhexis is done almost in slow motion. I had a doctor, another ophthalmologist, come watching, and he said he understood why it looks so nice, because we do it in slow motion. And it really is almost, for me, painstakingly slow compared to what we used to do. We used to do like a 3-rip capsulorhexis or 3-tear capsulorhexis. Now we do it very, very slowly, as you just saw, trying to achieve that perfect round rhexis, since we're competing with the femtosecond laser now. In terms of hydrodissection, this is really important to see these fluid waves. Here you can see a nice fluid wave being generated. And it's important regardless of your technique. I do phaco flip exclusively. It's more like a tilt and flip, as you'll see in a little bit. But if you're doing any cracking procedure, any of the procedures that involve chop, we did that for many years. You want to make sure your lens can rotate before you really get into those maneuvers. And so here we've tipped the lens up, and now we're just going in with the Stellaris unit using just position 2 to bring the lens over. And once the lens is over, we begin doing a normal phaco procedure, for phaco flip at least. The key thing when I talk about slowing down is you really want to protect the cornea. You want to wow the patient. You want to wow any referring doctor the next day. And you want to wow your staff, because they've got to buy into this technology as well. So you'll see that we do a certain, when we get almost all the way around with most of our lenses, we'll stop and put additional viscoelastic in, which is what we're doing right here. We're going to coat that cornea, and I actually tell the patient while we're doing the procedure that we're putting some protective solutions in to coat her cornea or his cornea, so that the next day their vision will just be as good as can be. And they like the fact that we're taking the time to do that. You have to remember that what you do and what you don't do will impact the patient every waking moment for the rest of their lives. It's an important thing to consider when you're in the premium IOL arena. That we're really looking for a lifetime improvement for that patient. And by taking the time to put the viscoelastic in, we really coat the cornea. We really can have pretty much pristine corneas the next day, except with the most dense lens. And here we're just slowly bringing this out, trying to control all the little fragments. And now we're ready to do the IA portion of the procedure. This is a wonderful reusable silicone tip from that Bausch provides. We can get 8 or 10 cases out of these tips. If you're careful, you might even get more than that. But it's a I typically use a 0.5 millimeter opening. This is at 0.3, so it provides really good suction, and I really am able to polish nicely with this silicone tip. Once the cortex is removed, I turn my attention to the underside of the anterior capsule, and here you can see what we're doing is we're using this tip to aspirate and polish the lens epithelial cells that are going to cause that capsule to get fibrotic. You don't want fibrosis to occur with a crystal lens, so you really want to take the time to do this. Dr. Gimbel talked about this years ago, and it should become kind of a part of what you do with crystal lens surgery, is to try to get rid of all the cells from the underside of the anterior capsule. I saw a patient of Jack Singer's that was months and months out, and I was struck by the fact that he had done such a good job of cleaning the capsule in this way that it looked like the patient had been done a few days prior to her visit with us. And that really convicted me and challenged me that I needed to go back and readdress how I clean the underside of the anterior capsule. So we're ready to put our lens in just about. We want to do a little additional cleaning. This is a Whitman polisher. Jeff Whitman came up with this polisher. It's a really neat use of a kind of a modified optical zone marker. And you basically can get this one, it has two ends, but you can actually rotate it in the eye and use it for both sides, or you can take it out and reinsert it to get the opposite side. But this will really allow you to get the area that's difficult to reach, which is kind of the subincisional portion of the capsule. And once this is done, we remove this. And we're ready to go ahead with the implantation of the crystal lens. You want to do this slowly, making sure that the lens is oriented properly. The large circular side is on the right as it enters, and the trailing haptic, the large loop on the trailing haptic, is on the left side. So last is left. And once that's in the bag, we rotate. I always rotate the lens to the vertical position. I think it might provide a little better accommodation in this position, but it's also a good way to test to make sure you're actually in the bag. If it doesn't spin, typically you're not in. Once I have the lens oriented properly, I then try to seat the lens by doing the little maneuver you see right here, where I kind of pull it from the capsular bag towards the center. Then place a stitch, and we place the suture before we remove the viscoelastic so that we don't lose the chamber, so the lens really doesn't shift. Once the lens is passed, or once the suture is passed, I go back and remove the viscoelastic material. And I try to make it a point to go underneath the lens as well to get rid of viscoelastic from beneath the implant. If you have a pupil that comes down, you want to be really careful doing this, because you can actually pull the lens, or you can pull one of the haptics out and not realize it's out of the bag. Here we're making sure that the eye is a little bit firm. I like to tie the suture under pressure. If you don't do this, you can induce unwanted astigmatism with your stitch. So I make sure that the eye is firm when I'm throwing this first suture. And once the suture is down, sometimes I'll check that pressure again, as I'm doing here. Then when the suture is tied and cut, we rotate the suture in so that the knot doesn't irritate the patient. And then again, we check the pressure to make sure that we're leaving this eye at an appropriate IOP.